Hello, and thank you for joining us for today's webinar, The Patient Access Champion and SDO, the starting line for improving the patient experience, sponsored by Centauri Health Solutions. Next slide, please. NAHAM promotes best practices, standards, and subject matter expertise, provides an array of networking, education, and certification opportunities, and enables our members to influence and promote high-quality delivery of patient access services. Just a few of our numerous membership benefits include those things seen on the screen and much more. Our membership is comprised of more than 2,100 patient access professionals across the country, and membership provides the unique opportunity to network with leaders in the field. Next slide. Before we get started, I have a few housekeeping notes. This presentation is being recorded, and all attendees will receive a certificate of completion following the webinar. If you have questions for the presenters, you can submit your questions during the presentation using the Q&A option seen on the screen. We will address as many questions as possible at the end of the presentation. To get us started, I'd like to introduce our speaker for today, Don Carter, Senior Director of Health Policy and Regulatory Affairs at Centauri Health Solutions. Don, I'll hand it off to you.
Good afternoon, everyone, and thank you so much on behalf of Centauri for joining us today for what we hope is a great educational experience related to the social determinants of health and health equity. And to piggyback off what some housekeeping items, we're going to have some interactive activities today, and I'll ask you to join the chat function to participate in those. And of course, I'll give more directions as we get there, but just wanted you to know that the chat will be open for that purpose. And we're really excited to bring you this content today. So here you can read about, why I am qualified to speak to you today about this particular topic. But what I would like to think makes me most qualified is this fun fact about me. I actually started my career in patient access back in 1995 when I was in nursing school, and I worked second shift in the admissions office of a local hospital. And at that time, information systems and technology were in their infancy. And as time went on, I found that I liked the business and technology side of healthcare better than the clinical side. So much to my parents' chagrin, I eventually changed my major to business since IT and informatics degrees didn't really exist yet, and thus began the career path that you see summarized here on this slide. And I'm proud to say that every step in my career journey has prepared me for what I do today, even the 2 times that I very briefly had a foray out of healthcare and into finance and accounting. And that was in 2000 and 2008. I very quickly saw the error of my ways and returned to healthcare for good in 2009. And then after that, joined the vendor side of things, developing solutions for risk adjustment, quality, various other revenue cycle applications, and have been with Centauri since 2015 when the company started. So I have a very soft spot in my heart for patient access. And so I was especially delighted to be asked to speak to this particular audience about a topic that you will see I am very passionate about. So without further ado, we'll just go over today's agenda. Just what are we going to be focusing on today? Well, we're going to talk about some of the key definitions and the impact of social determinants of health, also known as SDOH, on patient health and well-being. We're going to talk about the crucial role of patient access staff in identifying and documenting SDOH needs. We're going to talk about best practices for communicating with patients about SDOH in a sensitive and empathetic way. And then last but not least, we'll talk about some resources and support that are available to staff, such as screening tools and other workflow considerations. All right, so I thought I'd get us kicked off with our first interactive activity. And so for this, you'll want to pop into the chat and just let me know just by, saying, yes or no, how many of you feel, or like me, how many of you feel that you have a good knowledge base related to health equity and social determinants of health? All right, so a good thing we've got a lot of yeses. Couple not good, but that's great, because after this, hopefully you will come away with a lot of knowledge that you need. Some averages, some okay, somewhat awesome. Okay, So it looks like we've got, a good range of experience, which is, really awesome. Because if you answered no, hopefully you will come away from here with a lot more knowledge than when you started. And even afterwards, as you'll find out, I'm a very accessible expert. You are always welcome to reach out to me. So let's, without further ado, get started. All right. So we're going to start, before we kick off into some definitions and some things that I promised you in the agenda, we're going to do another brief activity, and I call this myth or fact. And so this is an activity just to kind of get us warmed up to kind of talk about these concepts that are related to health equity and SDOH. And so for this one, what you'll pop into the chat is the word, is this bullet a myth or is it a fact? And so what I'm going to do is I'll read the bullet. I'll give a few moments for folks to keep, popping into the chat, and then I will reveal whether or not it's actually a myth or a fact. So the first one is, an individual's diet is solely a matter of personal choice. Myth or fact? All right, myth, got lots of myth coming in there. Lots and lots of myth. Awesome. Okay, it is indeed a myth. Access to healthy food is often a social determinant of health issue, and you're going to actually see this in a slide that's coming up. Access to affordable, nutritious food, also known as a food desert, knowledge about healthy eating, and cultural dietary practices are significant SDOH that influence a person's diet. So that one is a myth. The second bullet, is an individual's neighborhood has an impact on their health, on their healthcare access barriers and on their health outcomes. All right, fact, lots of fact. Okay. Lots of fact. All right, that is indeed a fact. Neighborhood and built environment is an SDOH. Neighborhoods with poor air quality, lack of green spaces, unsafe environments, limited healthy food options, and high crime rates significantly affect health. Okay, number 3. If an individual has insurance, all of their healthcare access barriers are removed. All right. Lots of myth. Yep, false, myth. Lots of myth. And that is indeed a myth. Transportation, childcare, language, etc., can all still be barriers for someone, even if they've got health insurance. The next one we've got is myth or fact. Homelessness is primarily a mental health issue. All right, we got some mixed in. We got myths, a couple fact. All right. So for this one, this is a myth. While mental health issues can contribute, homelessness is a complex SDOH often driven by economic instability, lack of affordable housing, and systemic issues. It also exacerbates mental and physical health problems. All right, next is myth or fact. Focusing on a patient's social needs is outside the scope of patient access services. All right, lots of myths coming in here. All right, this is also a myth. It's increasingly recognized as crucial for holistic care. And I can't emphasize enough the importance of patient access professionals in the screening for workflows, anything related to health equity and social determinants of health. Next is myth or fact. Telling individuals to, quote, just have healthier habits, end quote, will not motivate them to improve their health. All right, lots of facts popping in here. All right, it is a fact. This grossly oversimplifies the complex interplay of social determinants of health. Telling someone to eat healthy when they live in a food desert or exercise more when they have an unsafe environment ignores fundamental barriers for equitable access to care. And we'll talk about what equitable access to care means here in just a bit. All right, myth or fact? It is the government's responsibility to address health-related social needs and determinants. Got some mix, so this one's more mixed. All right, this is a myth. Various entities have a role, not just the government. Communities, payers, providers, and the individuals themselves all have a role. And we'll talk about this in upcoming slides as well. And last but not least, treating everyone equally does not necessarily mean I am being culturally sensitive. All right, lots of facts popping in here. And that is indeed a fact. Treating everyone equally might mean ignoring their unique cultural needs, beliefs, or communication styles. Cultural sensitivity often requires treating people equitably, giving them what they need, which might be different for different individuals. All right, so hopefully now we're a little bit warmed up for our core content here, and we'll move on to some key terms. Okay. So as I begin to introduce our main content, I wanted to review the variety of terms that you typically hear associated with health equity, and they don't always mean the same thing. You often hear them used interchangeably, and they are indeed interrelated. And so I like to show how they are interrelated by saying this. We address health equity by addressing health disparities, by addressing social determinants of health, through assessing social risks and the needs that are associated with those risks. So hopefully that little equation kind of shows you how they are all related, but they're different, although you often see them used a bit interchangeably throughout the industry. And so what is health equity? Because that's the main concept that is above all. And this, of course, is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this because of social position or other socially determined circumstances. And I tried to choose a couple of graphics that kind of illustrate this, just to make it a little bit easier to see. And they're reflected in differences in length of life, quality of life, rates of disease, disability, and death, severity of disease, and access to treatment. And we're going to see some slides where you kind of see some actual dollars and things associated with this. And health disparities place a considerable economic burden on society. Total overall costs of health inequities and associated premature deaths between just 2003 and 2006 and earlier days amounted to just 1.24 trillion, and it's much more now. Experts estimate that eliminating health disparities during this time frame would have reduced this number by $229.4 billion. And of course, advancing health equity, as you saw on the previous slide, mandates that we pay attention to the social determinants of health. So let's dig in a little bit further. So what are social determinants of health? These are defined as the non-medical factors that influence health outcomes. And these are the conditions in which people are born, live, learn, work, play, worship, and age. And so there are 5 of them pictured here, but depending on the source, some people believe that there are up to 12 of them. So it's not, if you've seen literature that shows there are 12, you could make a case for that as well, because these are further subdivided by some sources. So these factors are estimated to be responsible for 80 to 90% of health outcomes and are not usually addressed as a part of a standard biomedical health assessment. Now, as a result, traditional medical care addresses only 10% of the controllable factors that make a population healthy. And someone in the chat noted that they call them social drivers of health. Absolutely. Not only that, but according to a recent report, 68% of patients have an SDOH, primarily financial insecurity or isolation, and 60% of these say they have never discussed these with a provider. So, as I observed earlier, it's highly likely that most of you have at least heard of social determinants of health. And judging by my initial question, there were lots of yeses. I'm familiar with this, which is great. And as I said, depending on who you ask, there could be anywhere from 5 to 12 of these. So let's examine a few of these a bit further. So let's take a look at just loneliness and food insecurity. So on the left-hand side of the screen, we have loneliness and isolation. And we have a statistic that says 20% of Americans are lonely or socially isolated. And so these are, as you can see, they're not isolated problems, and they have very real and large that are highlighted here in red. So ignoring them is not an option, and nor is hoping that the government or some other entity will take responsibility. These are very complex problems, and everyone has a part in addressing them. The government, payers, providers, members, and the communities in which they live. And certainly for social isolation, we see here some pretty sobering statistics by increasing mortality by 45%, increasing the risks of depression, anxiety, and suicide, and those costs associated with that. These are associated with a 50% increased risk of dementia. And it's very large costs that are expected to reach $1 trillion by the year 2050. And they are associated with a 29% increased risk of heart disease and stroke. And everyone here probably knows that those two illnesses, cost a lot of money and just straight healthcare costs, as well as lost productivity. And moving over to the right-hand side of the screen, we see that 1 in 8 Americans is food insecure. And the cost to the healthcare system with these reached in 2017 reached $327 billion. It's billion with a B, not including the costs that are associated with lost productivity and quality of life. And food insecure individuals are 50% more likely to develop diabetes, 14% more likely to develop hypertension, and 60% more likely to experience a heart attack. So you can see there are very significant costs that are associated with just these two social determinants of health. And I'm sure, again, it's probably not news to a lot of you, but sometimes it's pretty sobering to see these costs. Okay, so now this slide is one that I use frequently in presentations about this topic because it comes directly from CMS and does a great job of illustrating that many stakeholders in the revenue cycle have a part to play. So for those of you who might be frontline patient access staff, your role is likely to be included in the healthcare team. So this middle entity here, which focuses largely on screening so that SDOH specific ICD-10 and/or HCPC and CPT codes can later be assigned by coding professionals prior to claims billing. And so these are the folks that are over here on the right. And I actually give a version of this presentation that is specific to coding and other professionals that are involved in doing that. And it's actually pretty fun. We do some chart overread, of course, redacted for HIPAA, where they can actually see what these codes look like documented in medical records. So, and this is, of course, for patient access. So we're going to do some fun activities of our own that are patient access specific at the end. All right, so in later slides, we're going to be discussing screening a bit more in depth, since that's very relevant to this audience. So for those of you who might be in patient access leadership roles, your role is likely to fill over here on the left-hand side under the healthcare administrator team as shown to the left. And so here's the selection of tools, identifying workflows, especially related to things that belong to the EHR and the EMR systems, and just scoping out the procedures and the standard operating procedures that are needed to support the capture of these conditions. So it's also important to note that historically, capture of these codes has been pretty low. And there are many reasons for this, but one of them is because there's little financial incentive for providers to do so. Now, these SDOH screenings are actually now billable with a HCPC code of G0136. And so it is important that screening is performed and that the codes are captured to support the medical necessity of these codes, as well as enable tracking and trending of utilization so that people can see for the populations that are coming to their facilities and their clinics who actually has these conditions so that better outreach and better interventions can be developed for them. Now, the prevalence and capture of these Z codes, and you see down here, these are ICD-10 categories of codes, and there are a few others that are not listed here that are specific to trauma and abuse, but these are the ones that you see used most of the time. So the prevalence varies based on payers. Every payer has slightly different prevalence, and Medicaid claims in lines of business tend to have a slightly higher prevalence of these codes compared to commercial claims because this population tends to have a higher prevalence of these factors, mostly because, again, Medicaid is for low-income individuals, and so it makes sense, being that economic instability is a social determinant of health, these folks are going to have a higher percentage of these conditions. It also varies based on the setting. Z codes are observed in different frequencies across inpatient, outpatient, and other care settings. These codes tend to be captured more frequently in inpatient settings for the following reasons. Mostly because patients who come to the hospital for inpatient care have very severe health issues. So severity of health issues is one reason, and these may be directly influenced or exacerbated by social determinants of health. Another reason is because there's an intensive medical focus here. The inpatient setting necessitates a more holistic approach to patient care, where addressing social needs can be crucial for successful treatment and discharge planning. And so you often see in these scenarios social work staff being involved, financial advisors, other people whose job it is to make sure that folks have community and other supports after they're being discharged from the hospital. And again, it does things like prevents readmission, prevents conditions from getting worse, all sorts of other reasons. Another reason is because it gives increased opportunities for assessment. Longer hospital stays provide more opportunities for healthcare providers to assess and document SDOH, whether through direct patient interaction, social work involvement, or even other nursing assessments. Also, there is the potential for impact on outcomes and reimbursement. So recognizing and addressing SDOH during inpatient stays can improve patient outcomes and may be linked to certain quality measures and potential reimbursement in some contexts. So also, utilization and coding and documentation of these conditions also varies by geographic location because utilization rates vary by state and metropolitan area. They are particularly present in rural areas where it is harder for patients to access care, either because of the sheer lack of providers or their distance from them. And they also vary across the specific SDOH domain. Some Z codes, like those related to housing and food insecurity, appear to be more frequently used than others. This is often thought to be attributable to them being more visible and thus more likely to be disclosed by patients. And also because there are payment incentives in certain care settings to capture those ones as opposed to others. Because homelessness is a big one. And there are a lot of quality and other measures that are focused specifically on homelessness. We can expect in the future that this will expand, but right now a lot of the focus is on homelessness. There are also more clear-cut referral pathways for addressing housing and food insecurity compared to other SDOH. And certainly we expect over time that is going to change. All right, so this is the part where patient access folks will be particularly interested. And this is, we're going to talk about screening and the start of the patient's journey. And I mentioned on the prior slide that patient access role is heavily invested in the screening for these codes. And also mentioned is that there's great variability in their capture. So I thought I'd take a moment to talk specifically about screening and the various tools that are leveraged to collect these codes. Now, SDOH screening tools can be administered by the clinic staff or completed by the patient prior to the visit. There's a number of ways that this could be done. Now, your EHR, EMR likely has an integrated SDOH screening tool. And if it doesn't, inquire about the existence of one or the ability to integrate one. For instance, several common EHRs include templates with a few basic questions to assess family life, housing situation, education level, employment status, health insurance, all legal issues, safety issues, various things. These tools can be used to document social needs and communicate them to other members of the team, as well as ensure that they are accurately and completely transmitted to the billing and claim systems. Now, if there is not an integrated screening tool, you see over here to the right of the screen, there's a number of links here that you could go to if you needed a tool, or if you wanted a tool to serve as a template for something that you were going to integrate into your EHR, EMR. And the most common one is the Prepare tool. So out of all of these, Prepare is by far the one that is used the most. And actually, CMS refers to it quite a bit in a lot of their information that exists about health equity and SDOH. So in looking at the list of challenges that are presented here, it is important to understand that the first two, which we have lack of trained workforce and lack of operational policy, are more easily addressed through clear policy and standard operating procedures related to SDOH screening, and to ensure that any metrics and key performance indicators reflect tracking and trending of these codes. Now, the gold standard would be to do the following, and I'm going to give you a sample metric that translates into a KPI. And to do this, you might need the assistance of your informatics department or quality assurance analyst. These folks often have really robust technical backgrounds that can help you construct these queries so that you can report on this to know how well you're doing. And so the data sources for this would be your claims data, and you'd want to extract all the claims that have ICD-10 Z codes. So any of them that are in those ranges related to SDOH, which is Z55 through Z65. So any claims that have those codes. And then you want to also pull your screening data. And so pull your structured screening results from EHRs or care management platforms. And so these are the results from your Prepare, your social needs screening tools, whichever one tool, like from the ones here on the right side of the screen that you are using. And then you want to do some data matching. You want to match patients across both of those data sets using a unique identifier, such as their patient ID or an encounter ID. And then you also want to align it by date range so that you're looking at a specific date range. The third thing you want to do is categorize. And so for each patient or encounter, you want to put it in one of four groups. The first group is the SDOH is documented both in screening and in the claims. Group B is going to be your SDOH is documented in the screening only, meaning it didn't make it to the claim. Group C is going to be documented in claims only. And then Group D is no SDOH documented at all. And then your metrics to calculate would be your capture rate, which is a percentage of screened SDOH that appear on claims, and then your miss rate, which is the percentage of screened SDOH not reflected in claims. So that's just an example of, metrics if you just wanted something to start with or what something might look like. That's one that you could start with. Now, the most important part of this is closing the loop and following up with staff when you are applying metrics and KPIs. Where there are discrepancies or low rates, sit down with them and talk through some of the challenges they might be facing in their workflows, or investigate technical reasons such as the codes not translating properly from the EMR to claims. And luckily, that's a pretty easy fix, getting your technical team involved to make sure that they're extracting all of the diagnosis codes. Now, sometimes you may run into a situation where you have more codes in the EMR than is allowed on a claim. And unfortunately, sometimes that's the case. And if you're dealing with Medicare, Medicare fee for service, they don't really have a way to handle those excess, but a lot of other payers do. So it's really important to be aware of how payers handle that situation so that you can be sure that all of those are transmitted to payers. Now, for the patient distrust challenge, this one's a little harder to address because let's face it, patients are likely to be embarrassed about the situations in their lives that are SDOH, right? They can be really, really difficult for them to talk about. So in this case, I've got some, some guidance for you that may be helpful. So when we think about, cultural sensitivity, all the things we're going to get into a little bit more in depth. We'll talk a little bit more about, providers' reluctance to discuss SDOH with their patients, because they might feel that they can't do anything about these issues. They're kind of out, the root cause is kind of outside their realm. Things like homelessness, food insecurity. They may feel, wow, there's really not a lot I can do about those things. And that's true. So it is important, though, for health systems and health plans to provide clear pathways to referrals to appropriate resources. So although the providers themselves, might not have the ability to affect change, they can certainly provide the appropriate referrals so that the people who can connect them with resources, whether it's with the government, the community, or somewhere else, that they have this information. Now, if providers know that the information they are documenting will be acted upon, they will be more likely to be confident in their abilities to capture this information. Now, I will tell you that a recent survey of 280 patients that are enrolled in both Medicare and Medicaid, so these are dual eligibles, they are the most vulnerable population by far. And this survey revealed that 42% reported visiting the emergency room or urgent care at least once in the past year due to dissatisfaction with their doctor. And 33% said they postponed care following a negative experience with a healthcare system. Now, granted, this is often due to fragmented and poorly coordinated care and limited provider access, but communication barriers such as low health illiteracy, language barriers, and limited access and understanding of digital tools and support system also undermine their satisfaction with their care. So very complex to address patient distrust and the inability to address these needs, but I have some advice for you coming up here. So I would imagine that most of you in the audience work for entities that leverage EMR technology. And this is ideal, of course, from the perspective of addressing the patient distrust challenge we discussed on the prior slide. Now, the key here is to develop and document structured workflows, including a mobile intake process, which incorporates the screening template that I talked about earlier. Now, this provides a semblance of more privacy and dignity and eliminates the risk that others will hear these potentially sensitive and embarrassing conversations. Now, if a paper questionnaire is being used, we still have the risk of information not making it completely and accurately into the EMR, so it's best to reduce potential points of failure and just eliminate the paper, if at all possible. There's a lot of mobile technology out there. I know that even when I go for my own care or my children, there's kiosks, there's iPads, there's various ways to be able to screen for this so that people don't have the potential to overhear these very sensitive conversations. Because I know when I was working in patient access, and I imagine this might still be the case, you're in a booth, that may have some partitions, but you can still hear pretty clearly what's going on next to you. So this kind of eliminates, that risk and may make patients feel a little more comfortable in divulging these things that certainly affect their care. Now, if there's no way to incorporate the screening directly into an EMR workflow, there is more to do regarding physical safeguards to ensure privacy and use of scripting to guide staff conversations, including what to say to patients when they ask why the information is needed, because they may feel that it's invasive to ask those questions, and certainly certain cultures may think that it's very invasive. And staff have to be ready and willing to answer questions about why collecting this data is important and how it is used. So scripting is very helpful for this. And a good simple answer to this question is, it allows the provider to better understand other factors, including cultural ones, that are not medically related, that affect their health outcomes, and helps the provider care for them better. So now we'll talk a bit about cultural sensitivity matters and patient access. So as I was preparing for this presentation, I found myself reviewing the job descriptions for patient access personnel, because certainly they have probably changed quite a bit since I was there in 1995, late 90s. And the overwhelming majority specified cultural competence, and that's no surprise. And also sensitivity as required skills. Yet recent studies show that 7 to 15% of patients do not receive culturally sensitive care. And this underscores the importance of ensuring that patient access has a seat at the table when developing standards of care that relate to the administrative aspect of care delivery, because studies show that a culturally sensitive approach leads to improved patient satisfaction and care outcomes. And these bullets can also be used as a foundation for any training that you will need to ensure your staff understands exactly what's expected of them, no matter the types of tools and technologies that are used. So for those of you out there who are in leadership, particularly if you are, the ones, setting the overall policies and procedures, and you're kind of like, where do we start? This is kind of a good template to start from, and certainly insist at a seat at the table in developing, these processes and procedures, especially if you're collecting metrics and you see that there's a very low prevalence of capture. You want to make sure that you are included in those conversations so that you can have a part in making changes. Okay, so I promised a really fun interactive activity. And so we've got two scenarios. And so I'm going to explain how we're going to go about doing this. Because typically, when I give this type of a presentation, we'll break off into groups and do some discussion, but it's a little hard to do that here. So what I'm going to do is I'm going to ask that you practice your active listening skills as I read a case study. And then we are going to consider each of the 3 brainstorm bullets that you see here. And then I'm going to ask you to pop into the chat with your answers. So like we did with the myth or fact, as I say, so like, what are the potential cultural SDOH? Then you pop into the chat with your answers and we'll go over some of them. Now, for both of these scenarios, we are going to assume that the place of service for both is a provider's office. And the first one is Maria's missed appointments. All right, so everybody ready? All right. Maria is a 32-year-old single mother of 2 young children, a 4-year-old Mateo and a 1-year-old Sophia. She works part-time at a local fast food restaurant, earning just above minimum wage, and does not have paid time off or sick leave benefits. Her work schedule varies weekly, often with short notice, making consistent planning difficult. Maria has recently been diagnosed with type 2 diabetes and needs to attend regular appointments with a new endocrinologist to manage her condition, learn about dietary changes, and get on a new medication regimen. These appointments are crucial for preventing long-term complications. The clinic is about a 30-minute bus ride from her apartment. Now, here's how a typical cycle of missed appointments might unfold for Maria. Her initial appointment. She attended it, but with difficulty. Maria attends her first appointment with the endocrinologist. She had to ask her neighbor, a fellow single mom, to watch Mateo and Sophia, which was a big favor that was hard to secure, and the neighbor only agreed to watch Mateo. She was late because the bus was delayed. The doctor gives her a lot of information, which is overwhelming, especially with Sophia fussing in her lap because she couldn't find childcare and had to bring her. They schedule a follow-up appointment for 3 weeks later. So now we have Maria's first missed appointment because it's scheduled for a Tuesday morning. The Friday before, Maria's work schedule for the next week is posted. She's scheduled to work a double shift on Tuesday from early morning to late afternoon. She frantically calls her neighbor to watch the kids, but the neighbor has an unavoidable prior commitment. Her mother lives out of state and she has no other local family support. Maria considers calling the clinic, but she's exhausted after her shifts. The kids are demanding her attention and she honestly feels embarrassed and overwhelmed. She hopes to call in the morning, but oversleeps due to fatigue. So she misses her appointment. Now the clinic follows up. Patient access person from the clinic follows up and reschedules and calls Maria about the missed appointment. She apologizes profusely, explaining she couldn't find childcare. The scheduler, trying to be helpful, offers another appointment in 2 weeks on a Thursday afternoon. Maria tentatively agrees, feeling pressure to get her diabetes under control. She mentally notes to try and swap shifts or find alternative care. So the Thursday appointment approaches. Maria attempts to swap shifts at work, but her manager says no one is available to cover her. Her 4-year-old Mateo develops a fever and cough the night before the appointment, meaning he can't go to his daycare. Maria is now stuck. She can't work, can't go to her appointment, and has a sick child at home. Again, feeling defeated and ashamed, she doesn't call to cancel and has another missed appointment. So now, after 2 missed appointments, Maria feels like a bad patient. She's not managing her diabetes well, her blood sugars are high, and she feels guilty. The clinic calls again, perhaps with a more formal tone about missed appointments. Maria starts screening their calls, feeling that there's no point in rescheduling if she can't make it work. She begins to think that healthcare just isn't set up for people like her. Her health begins to decline as her diabetes remains uncontrolled. All right. So, for our first bullet, what are the potential cultural or SDOH factors at play here? All right. Everybody pop into the chat. Yep. Transportation, lack of childcare, finances, single mom. Yep. No childcare assistance, lack of family support. Yep. Neighborhood and build. Yep. We've got no help, childcare concerns. Yep. Transportation, unable to change the work schedule. All right. So we have, of course, childcare access and cost because she has a lack of affordable, flexible, and reliable childcare. We have her employment situation, which is, low wage, a part-time job with unpredictable hours and no benefits, so she doesn't have paid time off to be able to, take care of her healthcare concerns without being penalized. Transportation, reliance on public transportation, which can be unreliable and time consuming, especially with young children. Social support, limited family or friend support network to help her. Health literacy and stress, because she's overwhelmed by this new diagnosis, all this information compounded by daily stressors, which make it hard to prioritize and navigate the healthcare system. And this scenario highlights how interconnected SDOH can create a seemingly insurmountable barrier to accessing essential healthcare, even for a motivated patient. So thank you for all of that input. So our second bullet here is, how would you approach this patient with cultural sensitivity? This one might take a little longer to type into the chat. And you can certainly, just kind of say, telehealth. Yep, certainly we could talk about telehealth options, provide alternative transportation resources, offering that to her. Always good, maybe to have a list, for patients that are having these, transportation options that might be available. Van services, yes, because some, if she's got Medicaid particularly, a lot of them have transportation services that will come and help. Yep, suggesting virtual health, telehealth, free clinics. Try to offer later appointments. That's something also that a lot of providers in primary care try to do, is to have walk-in hours. I know that my pediatrician has walk-in hours. Outreach services, yep, could, and actually my pediatrician also has that. There is a social worker that assists with families who are having challenges. Offer weekend if available, family-friendly hours. Yep, earlier appointments while kids are in school. So we have a good range of things that we can do. So telehealth, extended hours, weekend hours, house call. That would be awesome. And there are actually, where I live here in Central Virginia, because that's where I'm located, there are actually doctors that do that. Yep, children need to come, bring them. I remember when my first child many years ago, I had to bring him to my postpartum appointment because I didn't have anybody to watch him. Linking with a church. Yes, it's always good to have a list, because maybe if a patient mentions, I'm experiencing some food insecurity, which could happen, especially with, a lot of these patients, having those resources on hand, like food pantries, churches, Meals on Wheels, various resources that might exist. And health plans, depending on what health plan it is, often have those types of services as well. All really good approaches with cultural sensitivity. And then also giving some leeway when she's late instead of turning her away without even asking if she can be seen. And there are actually one of the many other things that I do in my life is I'm a doctoral student, and so one of my areas of interest that I've written a lot of papers on is scheduling and scheduling algorithms that allow the most flexibility for patients. That's a particular area of interest of mine. All right, all good. And then, of course, the third bullet was what resources or solution would you offer? And we've got some good ones in here. Making sure that telehealth is made available, making sure that you have access to a list of, transportation providers. Um, if you're dealing with food insecurity, maybe, a list of, food pantries, Meals on Wheels, different types of situations. Um, Offering social services counseling, absolutely. Larger practices, like I said, and certainly hospitals tend to have those resources that can help connect patients like Maria to resources. And the key is, of course, cultural sensitivity, making her feel like her needs are seen. Yep, home visits if available. Try talking to the boss about situation in advance. It's super important, of course, for employers to understand that they too have a role in social determinants of health. And a lot of employers these days are actually embedding clinics, especially really large ones, in their operations so that there's like an actual like little urgent care clinic there. Um, and even, I have a friend who's a therapist who actually just took a job. She is in charge of setting up mental health clinics in large employers. So they have, as a part of their like employee assistance and their employee health programs. So employees will not only have access to health, actual, physical health care, but mental health care. Oh, you see, somebody, Volvo has a PCP office. Yeah, definitely you will see that. Pharmacies have clinics. And that's a good point. There are other options. So many more pharmacies these days have walk-in clinics or minute clinic. I think CVS calls theirs minute clinic. And even some churches have health ministries. That's another option as well. So lots of solutions, and certainly like I said, patient access services, because you all are the first point of care, are often the ones that are the best poised to offer this kind of help. Certainly clinicians may, and work when you establish workflows, involving resources such as, social workers, community health workers, and other individuals are a good way to also kind of close that loop in terms of when you identify somebody like Maria who's struggling, having someone to, support you after that need has been identified to get them connected to what they need. All right, very good. So our second scenario, we're going to call this Mr. Rashid's language barrier. All right, so let me tell you a little bit about this patient, and he's got also some transportation difficulties. All right, so Mr. Rashid is 68 years old. He emigrated from Somalia over 20 years ago. He is a widower and lives alone in an affordable housing complex. He speaks very little English, primarily relying on limited phrases and hand gestures. He relies on public bus transportation. Now, Mr. Rashid has been experiencing persistent chest pain and has been referred by his primary care physician for a cardiology consultation and an urgent stress test. He is anxious and clearly in discomfort. All right, so when he has arrived at the clinic, here's the scenario that unfolds in patient access. Now, Mr. Rashid arrives at the cardiology clinic reception desk. He looks visibly uncomfortable and he's clutching his chest occasionally. He approaches the patient access representative, Sarah, and attempts to explain his purpose for being there. He points to his chest and says, "Doctor, heart, pain," repeatedly, along with a few words in Somali. Now, Sarah seeing his distress but not understanding his language, initially tries to speak louder and slower in English, asking for his name and his appointment time. This only increases Mr. Rashid's frustration and anxiety. All right, so we have our first challenge is our language barrier here. So Sarah quickly realizes that the language barrier is significant. Instead of getting flustered, she remembers her training on cultural sensitivity. And so she doesn't immediately call for a family member, as that might not be appropriate or available, and professional interpreters are preferred. Instead, she accesses the clinic's language line, and she explains to Mr. Rashid with some gestures that she's getting someone to help them speak. Now, with the interpreter on the line in Somali, Sarah explains that she needs to check him in and confirm his appointment, but he's still very anxious, and through his interpreter, he conveys that he's worried about his appointment, and he mumbles something about bus and money. All right. So, for this brief scenario, what are the potential cultural or SDOH factors at play? We've got some in here. We got language, education, ethnic background. Yep, language and transportation are the biggest ones. Absolutely. And he's anxious. Yep. Okay, very good. So, how would we approach this patient with cultural sensitivity? So, just to get us started on how we would approach, language line was a good start. Asking for the interpreter. Letting the clinic know he's anxious, because if he's there for cardiology, that is certainly going to affect what's going on there. And Sarah, guided by, here's something that I wrote. Sarah, guided by the interpreter, asks open-ended questions about his ability to get to his appointments. Like, Mr. Rashid, are you able to get to the clinic easily for your stress test next Tuesday? Do you have any concerns about transportation for that day? Is there anything that might make it difficult for you to come? Yet being patient, using the interpreter services, letting him know that you are there to help, trying to get to the bottom of what would make things difficult for him. Yes, open-ended questions rather than anything, because it will elicit the most information. If you have an interpreter there, you can get much more information about what really might be happening. Yep, asking if he's in need of emergency services, for sure. If he's clutching his chest, for sure. And a good point somebody is about speaking with a financial counselor and having those folks available if necessary. So our next chapter of this, as we continue talking about cultural sensitivity, is through the interpreter. Mr. Rashid explains, the bus takes too long. My legs hurt. I used all my bus money to get here today. I don't have any money for next week's bus, and I don't know how to get a bus pass. He also mentions he's worried about the long waiting time for the stress test because he gets tired easily and he has no one to accompany him. So we know that here we've got some transportation factors here, some financial factors, some anxiety. Yep. Social worker would be a good call here. So I wrote down, Sarah could offer to connect him with the clinic patient's transport services, if there is one, Or if he's, like I said, a lot of Medicaid and Medicare organizations offer transportation services as with those plans. Also, a lot of towns, I know in one of the small towns that I'm close to, they actually have a little bus services that runs that will take people places. Now, she could also provide through the interpreter how to get a weekly bus pass, or if the clinic has a partnership, help him apply for one. She may even offer, again, this depends on the clinic and what your preferences are, loading a small amount on a prepaid card if there's like a little, benevolent fund or something like that. It just kind of depends upon what you have available to you. Offering a wheel chain, a chair for fatigue. Now, in terms of appointment scheduling, I felt that maybe recognizing his fatigue and anxiety, if I were Sarah, I would check to see maybe if there's an earlier appointment for the stress test so he's not worrying about it all day, or if they can arrange for him to be the first patient of the day. And she also flags the chart for extended wait time consideration. So if there's a way that he can have his anxiety reduced, maybe by having his appointment earlier in the day, that might help. Yep. And this is a good one. Any local Somali support group to find someone to accompany him. That would be a good, or anyone for that matter, to accompany him. And it may even, if he's got Medicare, for example, there may be even resources for that. Yes, and depending on age, some places do offer adult companions. There are actually companies, one of them is called Papa, that does things like that. And to that end, I wrote, Sarah could discreetly ask via the interpreter if he has family or friends who could accompany him. If not, she might offer to connect him with a volunteer patient escort program if the hospital or clinic has one, or at least ensure someone is checking on him during his wait. Because that's important if someone has to wait and someone's nervous, to have somebody checking in on you. And I also wrote down that I would make clear notes in the EHR about the language barrier, his transportation needs, and the need for a professional interpreter. I might also send, and somebody mentioned this earlier, I might also send a secure message to the nursing staff or social workers, alerting them to these barriers. And someone mentioned in Pennsylvania, there is paratransit that transports patients to and from visits. Yes. My grandmother, my maternal family is actually from the Pittsburgh area. And so I'm very familiar with Pennsylvania's services. And they actually have a lot of great medical benefits, like supplemental benefits that other states do not have. Go Steelers. I like that. My grandmother would be cheering you. Okay, so we've talked about how we would approach him with, cultural sensitivity, resources and solutions that we would offer. So our positive outcome of this scenario is Mr. Rashid feels heard and understood. His anxiety decreases significantly, which is good considering he's there for a stress test, heart condition. And he attends his stress test appointment because the transportation issue was addressed. And the future interactions with the clinic are much smoother because the staff are aware of his needs and are proactive in arranging the interpreters. Because I'm sure a lot of you can relate to having to scramble at the last minute for interpreters. That's really difficult. And he begins to build trust with the healthcare system. Because remember, we talked about on the earlier slide about patient distrust. So because of this positive interaction, he begins to build trust with the healthcare system, which leads to better adherence to his treatment plan. Now, this scenario demonstrated how patient access staff, equipped with cultural sensitivity and awareness of SDOH, can move beyond simple administrative tasks to becoming crucial navigators and advocates, which directly impact a patient's ability to access and benefit from their care. So we talked a little bit about scripting, and it can be really hard because a lot of these things kind of manifest on the fly, right? You might not know right away that these challenges exist. And so what's key is, being proactive about knowing, okay, for the population that our clinic or our hospital serves, the predominant needs are, and say it's transportation. And we talked about having possibly investigating, the different payers that have transportation services available, like Medicaid, for example, and Medicare. Having a list of other free transportation services. Like I said, maybe the city has a bus service. Maybe it is free for certain people. Knowing those types of things that are very specific to the population that you serve. Say it's food insecurity, having lists of food pantries, information for Meals on Wheels, churches that have food pantry, anything that you've got that can be on hand. And especially because you might not have time to call the social worker because sometimes we move from place to place in our care so quickly, you might not have time to call the social worker, but you've got your handy list. So it's always good to have. Or say somebody expresses they're having problems with, heaven forbid, domestic violence or those types of legal situations, even having, resources on hand that they can be referred to right away. So always good to take a look at the population you serve, know what the SDO, and this is for leaders, knowing what SDOH typically exist for the population, and then equipping your folks with knowing if somebody asks, says they are homeless, says they are X, Y, Z, you can have a list of resources right there that you can grab on the fly, especially if there's no time to call social workers or other staff to come assist. So also being able to answer questions, when patients, especially of other cultures, they may view it as invasive to ask about these things, making sure that they understand that these affect their health and that you will do everything in your power to make sure that, any barriers they have to care are addressed, because that's what health equity is all about. All right. So thank you for indulging me with my scenario. I know a lot of you are saying that you have to drop, but I wanted to conclude as we conclude our time together today, and before we have time for questions. You might be thinking, after this presentation, wow, these problems are so big, and I'm only one person. But as I mentioned earlier, providers often think this, and it's a reason why they might not document these codes. But I want to leave you with this perspective as illustrated in this story called The Star Thrower. And I like to read it. One day a man was walking along the beach when he noticed a boy hurriedly picking up and gently throwing things into the ocean. Approaching the boy, he asked, "Young man, what are you doing?" The boy replied, "Throwing starfish back into the ocean. The surf is up and the tide is going out, and if I don't throw them back, they'll die." The man laughed to himself and said, "Don't you realize there are miles and miles of beach and hundreds of thousands of starfish? You can't make any difference." After listening politely, the boy bent down, picked up another starfish, and threw it into the surf. Then, smiling at the man, he said, "I made a difference to that one." And so, with that, we will open the floor for questions of any type. But before we have questions, on behalf of Centauri and NAHAM, I want to thank you for joining me today. And before we take our leave today and have questions, I'd love for you to pop into the chat, those of you that are still hanging out with me, one thing that you learned today that you can take back to your daily work. And thank you for the very kind feedback. I appreciate that. There was the good information. So where there is a will, there is a way. Yes. Scripting for frontline, then continued communication with the team. Talking to patients, be a listener. The smallest gestures make the biggest impact. Absolutely. Always make time to help. Patient access can be watching for these SDOH, not just nursing, as it is mainly set up in the hospital. That is absolutely true. And I hope for you that that changes. The difference between being culturally sensitive, absolutely, all great feedback. And screening tools, yes. You please avail yourself of those screening tools if you don't have one. Backup to present to the hospital leadership to emphasize the need for this screening. Yes, please do use this presentation if you need to, or call me, I'll help. Look ahead at patients to see if maybe there are any who might need different types of assistance, especially if you are calling patients to confirm appointments. You know, a lot of us in patient access, do that. It might not be hard. Are you going to have any trouble getting here? Is there anything you need? And yes, everybody will get a copy of the presentation. And sharing the two scenarios, I can do that because I know that I just have them listed, but I could probably send something to NAHAM to distribute so that you have the scenarios. Collecting SDOH on pre-registration. Yes, that's another good way to address those barriers we talked about privacy and talking about sensitive things. Especially if you're the one, if you're calling patients to confirm appointments, it can be really helpful to have that information ahead of time, especially if transportation, childcare, any of those things is an issue. Being conscious that some may be embarrassed, absolutely, because sometimes, there are some of us, I'm probably one of those people, I don't embarrass very easily, but others do, and it's important to be sensitive of that. Very good. And thank you for indulging me. I always like to know, how people are going to take the information back to their teams and apply it. And of course, here is my contact information. Oh, thank you. You like my haircut. I love that too. Thank you. My contact information appears here. I encourage everybody to reach out to me via LinkedIn. My link tree is there. So I
Dawn,
have yes,
they can't click on the link tree. So can you put it in the chat?
I can. Let's see. I may have to send it along. Hopefully the version that goes out to the audience has the clickable link. It is in my LinkedIn. So if people go to my LinkedIn profile, the Linktree link is actually right there under where it has my description. So it's right there. And then there is my email address also. And so I encourage everybody to reach out to me if I can help you with health equity or SDOH in any way. I pride myself on being a very accessible expert. And with that, if there are any questions, I encourage anybody, pop them into the chat. And anything certainly we wouldn't get to, we would answer and get back with you.
Thank you so much, Dawn.
Of course.
In closing, we would like to give another thank you to our sponsor, Centauri Health Solutions, to our presenters today for sharing their time and expertise with us, and to our attendees for your participation today. As a reminder, a certificate of attendance will be available to all attendees in your NAHAM Learning Center dashboard. We also ask that you complete the post-webinar survey. For information on NAHAM, please visit naham.org or email us at info@naham.org. I hope everyone has a great rest of your day.
Thank you, everyone.